Welcome to the McGregor Dementia Support Ministry Podcast, walking alongside families with practical wisdom and steady encouragement. Today's breakout session from our February 21st, 2026 Alzheimer's and Dementia Seminar at McGregor Baptist Church is entitled, We Are on the Road, How Do We Overcome? Presented by Dr. Ed Shaw. In this session, Dr. Shaw addresses the common behavioral and mental health challenges that often accompany dementia, including agitation, mood changes, anxiety, and other difficult symptoms. He discusses both medication options and thoughtful non-medication approaches that can help caregivers respond wisely and compassionately. If you're navigating challenging behaviors and wondering what tools are available, this conversation offers balanced and practical guidance.
Welcome, everybody. I hope so far you've been enjoying the conference. My guess is that some of you are in this particular breakout because you have a loved one who's on the journey, as we say, and maybe you're having some challenges with their behaviors, or you're in the profession and you just want to learn some strategies. This behavioral challenges workshop I do as a full 6-hour training. And so we are condensing what's normally for me a 6-hour training into 45 minutes. So I've hit the highlights for you. I've got a little bit of a slide overview, but I really want to get to some questions and some discussion. And if you have situations that you want to bring up, you're among friends, there's no shame at all in this room. And so if there's a challenge you want to bring up and get some advice about, then please feel free to do that. So let's go ahead and jump in. So I told you in my talk this morning, this is my late wife, Rebecca. She was diagnosed at 53 with early onset Alzheimer's disease, and it was about 6 months after this picture was taken when I was serving her coffee in the morning. We always enjoyed our caffeine together every morning. And I'd gotten coffee. I went back to get the cream, and I was pouring cream into her coffee, and the sun was sort of shining through her hair. And I said, "Sweetie, your hair looks beautiful this morning. The sun is shining through it." And she looked up at me and she said, "I have no idea who you are." She knew the night before we had talked about our kids and, the things we talked about, and something happened overnight. And from that morning, she lived about 2.5, almost 3 years after this. She never knew me as her husband, married 36 years, together 40 years. We had 3 adult daughters who were in their mid to late 20s. She didn't know our girls as her daughters. She lost everything going back to about middle school. And still don't understand it. I've studied the brain my whole career, and I still do not get what happened in that moment. So you think about that story and you're very empathetic. I saw kind faces, but think about it from her perspective. So here's this guy, right, who gets in the same bed that she does. Well, that night, she did not want me in that bed. She did not know who I was. And we never slept in the same bed after that morning. She didn't recognize our home as her home anymore. She was living in a strange place, and her behavior dramatically changed from that day until the end of her journey. She started having, I call it the terrible day in August of 2013. Agitation, aggression, paranoia, marching around trying to leave the house saying, "I want to go home, I want to go home." Resisting care, I was helping her take her showers at night. Well, you don't want a stranger helping you take your shower at night. She had episodes of depression, and she began sundowning in a major sort of a way. So our journey became very different after that terrible day. So I want to frame the talk by asking you 3 questions. If a stranger tried to take your clothes off, would you stop them from doing it? Yes. Well, of course you would, yes. Have you ever screamed or yelled or moaned loudly when you were upset or in pain or in distress? Yes. And then if you were confined in a place against your will, would you try and find a way to escape? Yes. So, we, in the medical profession, these are called the neuropsychiatric symptoms of dementia. I hate that term. What I like to use is a term by an organization called the Dementia Action Alliance. It's daanow.org. They have a wonderful website. And what they gave me an appreciation from is what we call the challenging things that we deal with as caregivers, what we call, the difficult behaviors. These are just normal behavioral expressions that the person has. So if, we would call it resisting care if the person doesn't want us to help them with the shower, but if we're not familiar to that person, of course they're going to resist. Rebecca wanted to be home, Cedar Rapids, Iowa, 1960 something. She would try and leave our house in Winston-Salem, North Carolina. And, we call that exiting behavior or wandering. Well, really for her, she just wanted to go home. And I think that mindset of trying to kind of put yourself in the place of the person with dementia and understanding the behavioral challenge that they're expressing to you, that can be very helpful. It can help you be more empathetic in how you respond. So I don't have time to talk about all of these, but in the book, the Dementia Care Partners Workbook, I talk about the behavioral challenges that are more common sort of in the first half of the journey. So apathy, no desire or motivation, lack of understanding or insight, changes in how the person expresses their emotion, changes in that person's mood, the repetitive questioning, the lost identity, not knowing who their loved ones are anymore. This is a big one, is delusions of either someone stealing from them, or if it's your spouse, that you're cheating on them, or that you're trying to harm them. A delusion is when you believe something to be true that isn't true. So generally speaking, we're not trying to hurt the people we're taking care of, but they may think that we are. And that is a delusional belief. And then just behavioral disinhibition, that they may do or say things that they normally wouldn't have done, but now their brain is affected by this disease, and it changes the way that they behave. In the later part of the journey, the things that I mentioned with Rebecca, the agitation, the aggression, the emotional extremes, being all the way from completely withdrawn to maybe on the other end of the spectrum, like striking out and being aggressive towards the very people who are caring for them. The paranoia I mentioned, the exiting behavior, the sort of wandering, often accompanied by just a repetitive vocalization. Help me, help me. I want to go home. I want home. They'll just say over and over and over because they just become kind of obsessed with this thought. And then resisting care, the very care that they need for getting dressed or maintaining their hygiene or maintaining their nutrition and eating, they become resistive to even simple things like brushing their teeth. And then the sundowning, which is just a whole challenge that later in the day, late afternoon into the evening, that the person becomes more confused about who they are and where they are, and all of that sort of resisting care goes on steroids. So I want to just share a couple of more slides, and then we'll take some questions that you may have. One of the ways that I like to think about challenging behavioral expressions is like what the root cause is, like what could be going on, because you as the care partner, you're on the receiving end of it. So when I think about root causes, there are kind of three main categories of root causes. So the first one is, what's going on with the person with dementia? Are they manifesting these behaviors because of their underlying dementia? Maybe I talked about cognitive function. You ask them to do things, but they can't remember them. Or you ask them to do things and they can't understand what you're asking. This is all going to be issues related to the dementia that are going to make your care of the person more difficult. And so those are things that you often don't have a lot of control of, what's going on in the person with dementia. But sometimes it's things that are going on in us as the care partner. So a lot of the work I do now is I counsel caregivers who are taking care of a loved one with dementia. And sometimes caregivers can actually add to the challenge of caregiving. So depending on where the loved one is in their journey, if they're more advanced in their dementia, you may want them to do something, but maybe they're not able to do it. It's not that they won't do it, they're choosing not to do it to bug the HE double toothpicks out of you, right? It's just that they can't. It's like memory. People, the most common caregiver frustration that I hear in my office is they keep asking me the same question over and over. How many of you have heard repetitive questions? Okay, like 80% of the room. But it's not that they're choosing to ask the same question 2 minutes later. For them, it's a brand new question. And so one of the stories I tell is, so we had 3 daughters, and when they were growing up, they were always spilling their drinks. And so at one point I said to Rebecca, we've got to do something here because, the kids are always spilling their milk or spilling their soda or whatever. So we just decided we're not going to get mad until between the 3 of them, they spill 100 more drinks before they launch into adulthood, okay? So we just chose to respond differently, right? So when you can't change the circumstances, what you can change is how you respond to those circumstances. Now we got to 64, and then they were all gone, right? And I can't say that we never got mad again, but we did a lot better job. But in a way, it's like training yourself, because you, as the care partner, you have normal cognitive function, and you have a personality that's flexible and adaptable, right? And you can adapt to your loved one. The person with dementia does not have flexibility or adaptability, and they have a cognitive disorder. It's like I'll have a caregiver say, well, I explained, like I gave great detail, right? But if you don't understand, it doesn't really matter. So, you want to keep it short and you want to keep it simple when you're giving direction to someone, or you'll just model it. You can show them. Sometimes showing is better than telling. So it could be that the care partner just doesn't have the right expectation of their loved one, or maybe not enough training. Like there's now lots of good resources for caregiving. The third thing that we tend to really not think about is the environment. And so it can be that the environment the person is living in might be contributing to the behavioral challenge. So I'll give you an example. I was once asked by a memory care residential place in Winston-Salem. They had a client who was living with Lewy body dementia, and they said she's up all night and she doesn't sleep, and then she's really grouchy and combative during the day. So I actually went to the memory care place where she was, and it turns out she was in a room on the end of the hallway, and they kept her door open at night. And right outside her room was the fire thing, because it was a fire door. And that light was shining right in her face all night long. Well, that's an example of an environmental thing where, I said, just close her door. Well, we don't want to close her door. We're worried about her safety. Then put a monitor in there so you can hear her, or turn the light off at night. And it was an environmental thing that fixed the problem. Sometimes the environment is too complicated, like too much stuff in the house. Sometimes the environment is boring. I'm thinking of the place where your uncle and your aunt were, and they had the barest room in memory care that you could imagine. It was a bed and a nightstand, and there was nothing in there. I mean, I couldn't imagine being in that room. It was so boring. So sometimes the environment, and you can stop when you have a challenging situation, and you can just say, well, maybe what's going on with them, what's going on with their environment, and what's going on with me. If you're tired, you didn't get a good night's sleep, you might be grouchy, right? So when I talk about strategies, the strategies that often I think about that don't involve medication. So I'm going to show a slide on medications in a minute. But the strategies that don't involve medications are to be more patient. We heard grace and mercy. Dr. Mass was talking about grace and mercy this morning. Sometimes we need to extend that grace and mercy. We need to extend it to our loved one, and we need to extend it this way too. My middle daughter once said, after we had a terrible night caring for Rebecca, and she was literally climbing up the walls with her feet. She was so agitated. And, we did the best we could. And my daughter said to me, Dad, we can only do the best we can do, and we can't do better than that. And you know what? The person you're caring for has a cognitive disorder. If you didn't get it right, I promise you there will be time to get it right the next time, and you can learn, and you will do it better. And then you can teach it to someone like in one of the support groups. But being patient and just giving grace and mercy is really a helpful strategy. I'm going to apply the next thing called acknowledge, affirm, and redirect in one of the situations that you share with me today. But this is a strategy that I talk about in the Dementia Care Partners workbook that is really helpful in almost any situation that you encounter, no matter what the person says or what they do, you can apply that strategy. The 5 love languages can also be very helpful. We talk about that in the Keeping Love Alive, the Green Book. Just how you can spend time with the person, use physical touch, use affirming and loving words, do something for that person, or maybe give them a gift. How sometimes you can just rifle through those 5 love languages and think, well, what can I do right now where I can really show my love for that person? And then mindfulness. Mindfulness is just a way to sort of calm a situation, and I'm sure one of your examples will bring that out. One of the reasons I do a 6-hour seminar on this, probably more for healthcare professionals, is that there are medications that can be used to treat some of the challenging behavioral expressions, but these are very powerful medications. These are antipsychotic drugs that are used to treat schizophrenia, can also be used in treating people living with dementia. Anti-seizure drugs or anticonvulsants, and they both can be helpful in some situations. There are reasons why they might be helpful. The anti-anxiety drugs like Ativan, Xanax, Valium, they can be helpful. And then the antidepressant medications and sleep medications. Selectively, these medications can be very helpful. But also, you can use more of the non-medication approaches. So let's spend time, I would love for you to bring up just a situation that maybe you've had, and anything is fair game, and maybe we can brainstorm it as a group. So,
how do I get my husband, who is incontinent pretty much daily, to wear the pants?
Good question. How do you get your loved one to wear Depends to wear? So a couple thoughts come to mind. Incontinence is pretty much a certainty by the late stage of the disease. So initially, it begins with urinary incontinence, often with like a bedwetting episode at night, and then it just gradually, the person loses their ability to monitor like their bowel and bladder to know when it's full or the reaction time is too slow. So I think a couple of things that can be helpful to try and get them to wear. So it's a diaper, okay? I mean, let's face it, right. So the products have gotten better. And now there are these pull-ups that look like underwear. And that would be my first suggestion, maybe you've already done it, is to not call it a diaper, but to say we're going to wear these padded underwear now, and see if he might be more willing to wear a pull-up that looks like a pair of underwear. The other thing you might try and do is to put on his normal underwear. I don't know if he's a boxer guy or the tighty-whitey guy, but you might put on his regular underwear first and then follow that with a pull-up. And it may be that if he knows that the real, what he's used to is going on, that he would accept having the pull-up. If neither of those things work, because some people are really resistant, then you can, put on like a sweat pant or a more absorbent kind of pant that even if he were to wet himself or soil himself, it might give you a little more time to get to the bathroom. I do think that one of the things, and I don't know if this is true in your situation because I haven't heard your whole story, but sometimes it is a caregiver issue. Like, I know that my daughters, when they were very helpful caring for their mom, but they said, "Dad, I'm not going to be a rear admiral for Mom." Like, there is no way that I'm going to wipe Mom's butt. And they didn't do it. They drew that line. And so I don't know, it's a matter of dignity having to wear a pull-up, a diaper. And so sometimes the person can sense that, you're struggling with whether they should wear that or not. And then if you're ambivalent about it, they may feel ambivalent about it too. But, it certainly makes your life easier if he wears that. And it's probably better for him too. And so sometimes you have to move out of that spouse, it's your husband? Yeah, you have to move out of the spouse role, almost like you're parenting your spouse, and say, "Honey, we have to do this." And sometimes you can say, even if you don't want to do it for you, would you do it for me? Because I think people, even if they've forgotten, if he doesn't know you as his wife, he knows you as his care partner, his caregiver. And often people will be willing to do it for you, but sometimes you have to sort of be brave and almost say, this is for you and for me. We have to do this. Because otherwise, dealing with incontinence is really hard, and it can be dangerous. Somebody makes a puddle beneath them and they slip and they fall, and then you fall with them, and all of a sudden you've got two people out of commission, and that's not helpful. But it is a challenge.
He is adamant. I've he'll do much more for her than he will me. She's tried to get him.
Yep. And the hard thing is, you try and talk logic, but it doesn't work anymore. Yep. So I think just being persistent, trying every day, however many times a day, just keep at it. And eventually he will relent.
I have a comment.
Karen?
Yeah, I have a special needs granddaughter, and she needs to wear Depends, not diapers, but Depends. And I was trying to get her to put one on, and she refused. She wasn't going to do that. I said, well, what if Nana puts one on and wears one as well? Well, then that was okay. So we both put on a Depend that day and spent the day, and slowly she began to think it was okay and wears them fine now.
Great idea, yeah.
Possibility.
Yeah.
I want to hear your story. How that works.
We'll see. To be reported later.
Yeah. Is there another situation, another challenge? Yes.
I have a lot of clients call in that are very delusional as to what is happening in their life. The radio is going on and people are listening to her, and they're coming in through the radio waves or the TV channel. How do I don't want to discount them because they truly believe this is happening, but how do I respond so that I can move on to help them with other issues?
So the challenge is they see something on TV or hear something.
It's off,
but they imagine, I see, yep. So the person who has dementia is imagining they're hearing something, or maybe imagining that they're seeing something. So there are people who have dementia. It's more common with Lewy body dementia or dementia and Parkinson's disease, but it can be in Alzheimer's or vascular dementia or frontotemporal dementia, where the person has actual hallucinations, like they will hear something that's not really there, or they'll see something that's not really there, or they'll have a visual misperception. So they will see a cord like coming from a lamp going into the wall, and they'll think it's a snake. And that's more called a visual misperception than a hallucination. They're equally disturbing. So this is where I think we can go back to the acknowledge, affirm, and redirect strategy. Whoop, I went too far. So I think that what our tendency is to ignore the person and hope it goes away. And I think certainly you can do that, but for the person who's saying that, to them, it's real. So the first thing I would do is acknowledge what they're saying. So, I'll just pretend it's like Mom. Well, Mom, did you hear something from the radio? And so that's the acknowledge part. And then often the hallucination will make them feel a certain way, like maybe it might be frightening to them. That's probably the most common disturbing sort of hallucination, is when someone sees something or hears something that then makes them afraid. So then you can you can do a little bit of affirming. So how does that make you feel? Well, I'm afraid of what I saw or afraid of what I heard. That's the core issue. It's not so much what's coming out of the radio, it's how it's making them feel. So once you understand the emotion, like I always say, when you're not sure, go for the feelings. Even if somebody can't express themselves, their latent dementia, and you can try this if you have a loved one who's latent dementia, just ask them, how do you feel? We understand that all the way to the end. How do you feel? Even if you can't get the words out, you can tell how somebody feels by their expressions, their body language. And if the underlying emotion would be, well, I'm scared, that's a frightening hallucination, then you can use a little touch. You can say, well, I'm here with you, and Mom, I love you. That's the affirmation part. And you're safe. You are safe with me. Now, another thing is that sometimes when somebody becomes afraid, they'll start pacing. They'll be agitated. And this is where the mindfulness approach comes in. If somebody's pacing around and they're afraid and they're just going back and forth, and you're trying to follow after them and deal with whatever's going on, right? And you're never fast enough, right? So have them sit down. Because when we're connected, when we're physically connected to the ground, when your bottom is in a chair like it is right now, it will immediately calm you. And part of mindfulness is there's nothing fancy about it. So for those of you who practice mindfulness, it's just doing some intentional deep breathing. So if the person is agitated, like if the noise or what they saw got them upset, the first thing I would do before I tried to talk with them and acknowledge and affirm, I would sit them down. I mean, I think in a residential care setting, memory care, assisted living, that's the first thing that I think people should do is calm the person, right? So sit them down, because I heard in one of the testimonials that you want to sort of keep the drama level down, keep calm, right? So you're going to model calm. So Mom, just let's take a few deep breaths, right? Look at me, Mom. And already like the whole tenor. So Mom, what did you hear? Did you hear something? Did it make you afraid? How did it make you feel? And once, I think typically like when those emotions come out, then it gives you time. Well, you're safe with me, and I love you, and everything will be okay. Let's go turn the radio off. You could just pretend you turned it off, or click the clicker, or one of the 9 remotes you have for the TV, and then you might so acknowledge, affirm, and now I actually call it direct or redirect. Then you can direct or redirect their attention to something else. So you might say, let's go get some ice cream, or let me get you a cookie. Or would you like a little back rub? You can go through the 5 love languages, and just, kind of the acknowledge, affirm, and redirect. And it can be something the person says. It can be something the person does. The Alzheimer's Association has a much more complex version of this approach, but it just really reduces down to those 3 things. And it's easy to remember. Just acknowledge, affirm, redirect, acknowledge. And it works. It may not work the first time, but I promise you, if you practice this, it will help. And, even though the person, they may not remember the first time, with repetition, they will get used to kind of that process. So, as a long answer to your question. Yeah, you're welcome. Yes, sir.
Just wondering, I'm not a caregiver, but I feel for caregivers. I hear the stories of how they're exhausted. They've been up and not sleeping well, and they're frustrated. How do you retain the mindfulness? One moment at the Stupid Center came in, some of you may have heard of this, it's absurd, funny, but sad at the same time. They were walking out of church one morning, and the husband said, well, the husband has dementia, looks over and sees a boat going by on a trailer under the truck. He says, honey, we get home, let's get the boat out. We haven't had the boat out in a while. And she wasn't present. She wasn't mine. She said, honey, we sold the boat. And he screams coming out of church, what the?
Yeah.
But yet, I felt for her, because how do you be mindful of this? How do you do it more when you're exhausted?
Yeah. So the couple was walking, and he loved the water. He loved boats. He saw a boat. He wanted to, thought about a boat ride. And then his wife responded by saying that she sold the boat. So here's an example. This would be an example of where you then focus on the emotion, right? For him, what he probably does, he probably loves the water, right? So I might have said to him, what do you love about the boat? What do you love about being on the boat? That's emotion focused. Then let him talk about loving to be on water. Not that she sold the F-bomb boat, right, out from underneath him, because that's just going to sort of bring up the drama. But could have been a moment to sort of sit down and say, oh, we used to boat. I love being on the water with you. Tell me your favorite time we were boating together, right? So just focus on the emotion. I say this over and over, but it really, because generally when the person says something, there is this is true for all of us. I mean, often things we say are because we're feeling something on the inside. I was doing that long day training on behaviors, and I had a physical therapist who was saying, I have this lady that I go to her room, pick her up for physical therapy, and then take her. And on the way back, she always tells me that she's going to introduce me to her mother. Now, this lady was 90-something years old, right? And he said, I didn't know what to say to her. Like, obviously, I know she had her own room. Her mother wasn't in the room. But what that person is telling him is that she misses her mother, that she loved her mother. And so I said, just take her to the room and sit down and ask her mother's name. Don't remind her mother died 25 years ago. A lot of family members will do that when somebody's talking to their deceased mother or deceased parent. They'll say, oh no, she died 30 years ago. What was your favorite thing about mom? It's back to the feelings thing. Tell me how much you loved her. And it's really just because that expression, that emotional expression it's part of them, like Dr. Mass said, it's honoring the ability of that person to tell their story. And they may not tell it as well, but they'll be able to. Yes, Keith.
Something similar. My wife is a twin, and she's always telling me, Susan was here and left, and then left without me, and didn't tell me where she was going. And Susan lives in Colorado and hasn't been here for a few months, and so she hasn't seen her other than maybe a FaceTime. But would that be the same thing? I
think that would be the same thing, and it's the general idea. I talk about it in the book. It's based on what's called attachment science. So if you remember back from your psychology classes in college, if you took those, talk about like how human beings form relationships. So we start forming relationships, some people say in the womb, but certainly from birth.
Twin.
And a close relationship with a twin, yep. And so we call these attachment figures in our life. They're the people we love. And some attachment figures we have for a lifetime, our family, spouse, children. Some attachment figures come and go, like especially friends during high school or college or maybe with a job. But often people with dementia, they become challenged in their attachments. And so probably your wife's twin might be, one of her top few attachment figures in her life. And if she no longer cognitively, can remember that when her sister is not with her, she might feel like her sister's just gone, like she's not in my life at all. And she might start calling out for that parent. And this is really common in people with dementia, or just even people with advanced cancer, people who are dying. They'll call out to a strong attachment figure in their life. Mother, the mother is always sort of top on the list, but could be parents, siblings, other family members,
Time, 1:30.
Time?
It's 1:30.
No, we have 4.5 more hours. So for those of you who don't come here, there is a wonderful support group that Karen helps co-facilitate, and the support groups are great places to bring up some of these challenging situations. But yes, sir.
Two things that I've learned.
Okay.
It's always a learning. Every day is learning. One of them is, remember the phrase "little white lie"?
Yes.
It doesn't exist. It's called compassionate deception.
Compassionate deception.
The other one is kind of an acronym, and it's ACE. And ACE stands for don't argue, don't correct, and don't explain. That's the ACE.
ACE. Good.
I carry it like a wallet.
Good.
Because
Thank you.
it works.
Yeah. Well, are we dismissed?
Any quick suggestions to get my husband to shower who used to love water and now
Okay. How do we get our loved one to? Sorry, if you stay too long in here, I'll get in trouble from Kim. So I think sometimes if you can bring in a caregiver who might be able, like a paid caregiver, sometimes that person will be more willing to bathe or shower, and it's that person's job to get your loved one to do it.
and a man preferably over a woman maybe?
It depends.
Unless she's young and pretty.
There are not that many male caregivers, that many male CNAs, so it's hard. And, caregivers are trained to sort of, they just take care of males or females. But I think it's another one of those things like the question Linda asked that, the person needs to maintain good hygiene because poor hygiene is a risk for things like urinary tract infections. And so then it's just being in the habit of, and even being a little bit persistent.
Are they afraid now of the water, most dementia people? I don't mean to classify, but
Sometimes people do become, or people with dementia are often hypersensitive to touch or sound or temperature. That part of their brain gets messed up. So what feels like a nice warm shower for you or me could feel scalding hot or maybe way too cold. So I'll stay up here because I don't want to keep those of you who want to. Oh, actually, I have to go because I have to do the Q&A session. But I'll be around at the end too if you have other questions. So.
Thank you for listening to this important session. If this episode provided helpful insight into managing behavioral and mental health challenges, please subscribe and consider sharing it with someone who may benefit.